Hi, everyone. This is Dr. Shannon with another episode of BBC One Take. We're in the BBC One studio today with Dr. Adrian Owen, who is a neuroscientist, and I'm really excited to have a conversation with him. Dr. Owen, I was hoping that you could start by talking a little bit about your background.
Of course, yeah. As you've said, I'm a neuroscientist. I work at the University of Western Ontario. I'm a professor of cognitive neuroscience and imaging. So what I do is a lot of brain imaging using techniques like MRI and in the past positron emission tomography or PET. And we develop tools both for assessing people's cognitive function, but also for looking at their brains with these neuroimaging techniques.
And Dr. Owen, I was reading up about you. I know that you've had some particular work that's come out that's been groundbreaking that others hadn't recognized before. Maybe you could talk a little bit about that.
Sure, yeah. This goes back about 25, more than 25 years now. I began in the late 1990s looking at whether we could detect any signs of awareness in patients who were behaviorally non-responsive, who apparently would be diagnosed as being in a vegetative state. And that means that they open their eyes, they sometimes look around the room, but they won't fixate on anything in particular, and they certainly don't respond to anything. If you say, squeeze my hand, nothing will happen, or blink an eye, nothing will happen. So it's assumed that they have no awareness. But because I was an imaging guy, I'd done a lot of brain imaging up until the late 1990s. I thought at that point, maybe I'll try and see whether we can understand a little bit more about these patients. And it really came to a head, and I think this is what you're referring to in 2006, when we used fMRI, functional magnetic resonance imaging, to show for the first time that we could actually detect conscious awareness in a patient who was assumed to be vegetative. And this was a young woman who'd been involved in a road traffic accident, very badly damaged as far as her brain was concerned. And for 6 or 7 weeks, everybody assumed she had no awareness. She didn't know who she was, where she was, and the situation that she was in. But using brain imaging, we were able to show that, in fact, she was completely conscious. She knew where she was and the situation that she was in. And this has really produced an entire, industry of people looking at these sorts of things. Well over, in the last 20 years, it'll be 20 years next year since we made this discovery. And over 1,000 patients have been put through this procedure now. And many of them have been shown to actually not be what they appear to be at all. They're actually conscious.
Wow, that's amazing. I would love for you to talk a little bit about, if you could expound on how has that then changed how we think about these patients, right? Because in the past, I think that folks thought, oh, there's no coming back, but you've obviously shown that, like you said, that there's awareness there. How has that changed medicine and how we think clinically about these patients? How maybe we treat them?
I can probably best answer that by telling you what my former dean of medicine at the university said when he was introducing me one day, which is that no one ever walks into a ward or a room with a patient like this and assumes that they're unaware anymore. As you said, I think up until our paper in 2006, it was widely assumed that these patients weren't aware, which means that you could make decisions about them without consulting them. You could have conversations in their presence without worrying about them witnessing what was being said. And obviously, in some cases, you could make decisions about whether they live or die based on withdrawal of life-sustaining treatment. And I think it has changed all of that now. I think largely people assume that patients have awareness until proven otherwise. I see this all the time in the hospital, that both staff and families will assume that the patient understands what's going on in the room and treats them accordingly. I think that's probably one of the main things that's changed, is that the patients get treated very differently. As in fact, as the very first patient we scanned more than 25 years ago told me recently, she went on to recover. And so we regularly have conversations. And she told me recently, the day you scanned me, I went from being a thing to being a person. And her feeling is that the way she was treated changed overnight. I've seen this many times since then. So I think it really has changed the way these sorts of patients are treated.
So many questions that I could ask you. I would be curious to know, I know that you talked about imaging. Are there other conditions or other things that you found in your work besides this? And this is huge, I know, but are there other things that you've come across or things that you've noticed in the body of research that you've conducted?
Oh, for sure. Yeah. It's funny, imaging work is very much conducted in parallel with my other great interest, which is cognition, which is understanding how people think, how people attend, how people make plans, how people lay down memories, these sorts of things. And that was really where all this started. When I was a graduate student in the late 1980s, I started developing tests to try and really get to the bottom of what was the problem in the brains of people that struggle with some of these cognitive abilities. And that was a very different way of doing things. I guess I didn't really realize I was doing things very differently back then, but looking back, up until then, people had not really didn't really care about the brain very much. They just cared about performance. And most traditional cognitive tests just measure how good you are at something. How many things can you remember? How long can you remain focused on a particular stimulus and these sorts of things? And or how easily can you sort a pack of cards? That was, I guess, cognitive psychology or neuropsychology through the 1970s and 1980s. And when we started doing our work in the late 80s, my graduate studies, I was really fascinated by the brain and trying to understand not just why can't somebody sort a deck of cards, but which bit of their brain has gone wrong or is not working as well as it should do that is causing them to not be able to sort a deck of cards. And that really, as I say, I didn't do this intentionally. It's just looking back, that's how things worked out. And on the back of that, we created a whole suite of tests that essentially measure different aspects of brain function. So, sorry, it's a very long answer to your question, but what it means is that we can look at somebody, for example, a patient with Parkinson's disease, we can test them on our suite of cognitive tests. And not only can we say this person has problems with, say, their ability to make plans because of their Parkinson's disease, we can also pinpoint why that is. It's a problem, for example, with their frontal lobes or a particular part of their frontal lobes that's leading to impairments of planning. So that example is a real one. In my PhD work, I did a lot of work on Parkinson's disease, understanding the cognitive deficits of the disease. Many people will associate Parkinson's disease with just a movement problem, problems with tremor and stiffness and these sorts of things. But actually, Parkinson's patients have a lot of problems with thinking as well. And we've identified over the years many of the different brain structures and networks that lead to the sorts of difficulties that patients with Parkinson's disease have. And of course, one more example is dementia or Alzheimer's disease. This sort of led me in that direction because many patients with Parkinson's disease also go on to develop dementia. And it became very important over the last sort of 10 or 15 years to differentiate those things, differentiate the different types of dementia. Is this dementia that follows Parkinson's disease? Is it Alzheimer's dementia? Is it frontotemporal dementia? And all of these different conditions are, I think, best defined by the actual pattern of cognitive impairments that you see when you test them on rigorous and scientifically reliable tests. So that's what I do when I'm not brain imaging, is I test people's brains, but with cognitive tests.
That's fantastic. And I have read about the Owen Lab. I don't know if you want to talk a little bit about that. Before I start, I'm going to ask you some other questions about some
Sure.
of the findings, but that would be great.
Yeah. So the Owen Lab, as I said, we're based at the University of Western Ontario, and that's in a city called London, not London, England, but London, Ontario. And I have quite a large group, and I would say they're roughly divided into two different groups. Half of my graduate students and postdocs, half of them work on serious brain injury. So we're right opposite the university hospital, literally across the road. So every day, half of my team are over in the ICU looking or assessing patients who've recently sustained a very serious brain injury. So these are people who are typically in a coma. They may have had a traumatic brain injury in a road traffic accident. They may have had a near drowning incident where they've been underwater for too long and their brain has been starved of oxygen. They may have had a cardiac arrest, again leads to oxygen starvation in the brain or a stroke, many different reasons. But those are the patients that half my team examine in order to try and understand exactly what's gone wrong in their brain, where the damage is, and crucially, if we can predict who's going to recover. And this is a really important issue that we're working on at the moment. Can we improve prognostication, as it's called, your ability to predict who is going to recover and who is most likely to die? The other group of graduate students and postdocs I have work on the cognition tests, the tests that we developed for the Creyos platform. And we do a variety of different things. Just to give you an idea of some of the projects going on at the moment, one group of students are looking at cardiac bypass surgery. They're looking at patients who have bypass surgery because among cardiologists, there is a phenomenon that's often referred to as pump head, which is that you've spent too long on a cardiac pump during the course of surgery. It can leave you something like brain fog, some cognitive impairments, some cognitive challenges, and trying to understand the relationship between what goes on in the surgical suite and what causes those effects is a really interesting dynamic. And the reason is because there are many different ways of doing cardiac surgery. There's not just one. And any cardiologist will tell you some people prefer this method, some people prefer that type of anesthesia, some people do this or do that. And it's not clear which of these procedural differences are causing the cognitive challenges that many of these patients experience. So we're measuring cognition using Creyos before cardiac surgery and after cardiac surgery in many different types of cardiac patients to try and understand what's at the bottom of that relationship. What is it that's causing cognitive challenges? Anesthesia. I'm really fascinated by anesthesia, partly because it's the best model that we have for things like the vegetative state. Somebody under a general anesthetic, they don't respond. They don't know who they are. They don't know where they are, but they're still alive and they're still breathing. They're very much like a patient who's in a vegetative state. So we use it as a model for understanding what the brain can and can't do in that state. And we literally put people into a scanner, or we give them our cognitive tests and we give them an anesthetic agent, something like propofol, put them to sleep and examine their brains while they're asleep, and use that to draw conclusions about what might be going on in the brains of patients who appear to be comatose or vegetative.
That's fascinating. And that is a great segue into my next question. So I was just thinking, there's a lot of talk about people are living longer, maybe not necessarily healthier. Definitely the case, I think, probably could be argued here in the United States. But just thinking about the work that you've done, and even recalling back the patient that you said that she went from being a thing, right, to being a person again. How do you see this work influencing how we think about patients and think about aging, knowing that, and from what I've heard, that life expectancy is going to increase significantly within our lifetime? So just thinking about the medicines that are available, the treatments that are available, and how that might be impacting patients and the connection, right, to our cognition and how we're aging in our brains.
Yeah, that's a great question. So a lot of the work or the research that goes on in my lab, whether it's using the Creyos cognitive assessment platform or whether it's using brain imaging, its aim is prediction. It's trying to predict what's going to happen in the future. And that might be predicting a brain injury patient, where are they going to recover? And if so, what sort of recovery are they going to experience? Or it might be a patient who has presented with something like mild cognitive impairment, say somebody in their mid-60s that says, my memory is not as good as it used to be, having trouble concentrating, I'm making mistakes. It's extremely common. And what's very important with these patients is that we try to differentiate who among them is on the early road to a dementing illness and who is actually just coming to terms with the challenges of aging that many of us have to do when we approach that sort of age range. And both of those things are equally important to my mind with the dementing sort of trajectory, if you like. Here it's really important because there are more than 30 drug trials going on around the world for dementia-related drugs at the moment. Now, we all know that there's no magic cure. There's nothing available right now that's going to cure your Alzheimer's disease. But there are certainly things that will slow it down and things are moving very quickly. Who knows, 2 or 3 years from now, we may have a drug. And what we do know about all of these drugs is that the earlier you get in, the better. The milder the impairment is to start with, the more easily it is to ameliorate it, slow it down, or whatever. So regardless of how long it takes for us to get a, I'll say, cure for something like Alzheimer's disease, it's going to be clear that early detection is key because people need to get in there quickly with the drugs. Also, for that population of patients, on the sort of, I suppose, the rather more or less optimistic side, is planning. If you know that you are on the road to dementia, then if you get in early enough, you're still cognitively able to make plans, to organize your life accordingly, organize your finances, these sorts of things. So it's very important population. On the flip side, of course, it's equally important for people who haven't got dementia because they also, you want them to plan appropriately. You don't want to be planning your demise with dementia if that's actually not what's happening. You're just aging like the rest of us. So early detection is really important. And there are many different methods that we're working on, particularly in the dementia space, to try and detect dementia where it's occurring as early as we possibly can. And I think that's going to have a really enormous impact. And as you say, the population is getting older. So we're getting more and more people who are actually, we often refer to as the worried well. So they're actually going to be okay. At least they're going to be able to continue with their normal activities of daily living. They're not going to die of illness. But still, life is going to become more challenging. As they get older and older, they become more frail, and various everyday tasks become more challenging. I think that the predictive piece and the diagnostic piece go hand in hand, and they're both really important.
Earlier, you mentioned about other types of dementia and other conditions that affect the mind. Would love for you to talk a little bit about that and why that's significant as opposed to lumping everything, say, together as Alzheimer's dementia. Why is the distinction important or the differentiation?
Well, I'll give you an example of a patient I saw just last week who I tested using the Creyos battery, and she clearly had some cognitive challenges. And this was not a very old woman. This was somebody in their late 50s, and that's about my age. And of course, her immediate response was, okay, I'm dementing. And I said, that may not be true. I would at least need to see you again a few months from now, because if you're dementing, by definition, you get worse over time. And there are many things that could have resulted in this patient having poor cognitive function that don't deteriorate over time. Maybe she had a bang to the head. She has some kind of concussive symptom. Maybe she has had, well, I've certainly seen cases like this. She's ingested some substance or inhaled some substance that has affected her brain. Maybe she's had an infection like COVID that has led to brain fog. So that's the first point, is that just because you're older and you've got cognitive challenges, it doesn't mean you've got dementia. And it's really important that we differentially diagnose those things, because it's one thing if you've got cognitive challenges and you're going to get worse. It's quite a different thing if you've got cognitive challenges and you're just going to live with them, but that's the way it's going to be for the rest of your life. And that's a very important distinction. The other point that this patient made is, she said, this is awful because there's nothing can be done, is there? And I had to correct her. So it depends. If you are demented, you do have dementia, it depends exactly what kind of dementia that you have. So let's take we all know about Alzheimer's disease. Very difficult to deal with that and to find any sort of type of treatment. But there's a whole different type of dementia known as vascular dementia, which is caused by, something like mini strokes is probably the best way to describe it. Strokes that you don't even know about, that you might have in the middle of the night, and over time they add up. And they add up and they affect your brain and they affect your ability to think and perform cognitive tasks. Now, I'm not saying that vascular dementia is treatable, but at least there's some interventions that one can do. One can work with blood pressure, can work with vascular issues related to clot busting and other types of stroke reducing or risk reducing stroke medications to slow that down. There's an example of why it's really important to get it right. And unfortunately, we live in a world where these things will typically get lumped together. If somebody says you've got dementia, they'll think, okay, I've got Alzheimer's disease, but it's not always the case. And it's important that we do differentiate between them. That's what developing these tools is really about. Can we tell the difference between one and the other?
I want to talk about the tools, but before we go there, you mentioned COVID-19. I'm actually doing my own study. It's a phenomenological study on how the interaction of physicians and patients with the healthcare system has potentially changed. Don't know yet, but it seems so in the early interviews. But I know that there was a lot of disbelief that there was actually an effect in the beginning, and was whether or not there was something that was truly COVID brain. And I think that's something that our audience or healthcare leaders that maybe they want to be aware of as well, as to how they might plan for impacts or effects that we'll continue to see on the horizon. Could you talk a little bit about COVID brain and
Of course, yeah.
what you're seeing?
Yeah, we actually published a study, let me see now, 2023, I guess. We were very lucky, I suppose, in that when the pandemic hit, we already had in place this sort of suite of cognitive tests that had been developed in my lab. So suddenly everybody wanted to go online. Everybody that was testing people face to face up until that point was suddenly looking around trying to find online tools they could do the same thing. And we've been using them for 20 years at that point. So we were really well positioned to look at COVID, and we actually started testing about 4 or 5 months into the pandemic. We were ready to go, and we needed to raise a little bit of money grant money to employ graduate students and people to actually get this thing going. But we were really quick off the mark with our COVID study. And so it came out, I would say, just as the paper came out, just as the pandemic was coming to an end. And it was fascinating. We followed several hundred people who, from a little after the point that they were recovering from COVID infection, and we measured their cognitive function as they recovered and as they got better or didn't in some cases. And we identified 2 different COVID syndromes, if you like, 2 different kinds of long COVID, you might call them. One that clearly affects cognitive function, clearly affects your ability to think, your ability to reason, your ability to make plans. There's absolutely no doubt that exists. It doesn't happen to everybody. It happens in a subset of people who have COVID. But what I found most fascinating about it is it's not related to how bad your COVID infection was. So regardless of whether you had a mild sniffle and still worked through it, or you ended up in the ICU, the long-term cognitive deficits could be the same. Now, the other type of COVID, the other type of long COVID, was related to mental health symptoms, things like anxiety and depression. And we showed that many people coming out of COVID had higher scores on standardized questionnaires of anxiety and depression and these sorts of things. And what was fascinating about that is that, excuse me, is that those symptoms were related to the severity of the infection. The worse your infection was, the more likely you were to suffer mental health consequences, if you like. But I guess the third, I keep saying what I found most fascinating, but I found a lot about this really fascinating. The third really fascinating thing is that the 2 things were quite different. They didn't overlap. So just because you had memory and planning and problem-solving difficulties didn't mean that you were going to be depressed and anxious, and vice versa. These two things seem to coexist quite separately. You could have both, but having one didn't necessarily mean you had the other. And that, to me, tells you that there's probably 2 different mechanisms. COVID is probably affecting the brain in different ways in different people, because you can have one and not the other. And typically in neuroscience, that tends to mean that the underlying problem is different in both. So it's interesting. COVID clearly does have effects. It has multifaceted effects. But unfortunately, we can't predict in any one individual exactly what those effects are going to be.
And that, just one last question on the anxiety and the depression. I can hear or think most people would be like, oh, it's because they were isolated and they lacked relations. And so that depressed them or made them overly anxious. But it sounds like that there were actual structural or chemical biological implications. Did you feel that or find that or
It is, of course, difficult to tease these things apart because there are many psychosocial factors that could also have contributed to anxiety and depression. People were losing their jobs, people were failing at school, people were not able to go to school. There are many reasons why their lives were affected in ways that may lead to anxiety and depression. We did statistically find a way to unpack that and show that it seems to be more likely related to the disease itself than other factors going on in the world that might have led to impairment. So we think it is to do with the infection itself rather than these additional factors. But you're absolutely right. It's difficult to be absolutely sure that these things are independent.
amazing? Thank you for sharing that with me. I want to talk about the work that you're doing with Creyos, the tool that you're using. Let's talk a little bit about how you came by Creyos, or maybe they came by you, how that relationship started, and what's the work that you're doing there? Because I know you've mentioned a few times now that you're using that tool to do
Yeah.
testing in your lab and in your own research.
That's funny, or at least it's funny from my perspective. I actually gave birth to Creyos.
Awesome.
It was something that came from my lab, and it was never intended to be a commercial enterprise. I started working on this idea back in 1988. I was a graduate student in the UK, and as I said earlier in the conversation, I started to develop cognitive tests that would really get at different brain structures and brain functions. I would travel around the other London, England in my battered old car, visiting patients that a local neurosurgeon would send to me. And I would test them in their homes, and I would try and work out what was wrong with them, what were their challenges based on these tests. And then I would go back to the lab and tweak the tests to make them more sensitive to the impairments. And gradually I built a map, if you like, of the relationship between brain damage, performance of our cognitive tests. I then came out to Canada for 3 years. I worked at the Montreal Neurological Institute. It's a very famous Canadian institute founded by the celebrated neurosurgeon Wilder Penfield. And I worked there with Brenda Milner, who coincidentally turns 107 today. And we worked on, again, using these tests. These were the early 1990s, and it was the early days of neuroimaging. So we had PET scanners and later fMRI scanners, functional magnetic resonance imaging, and we would put healthy people and patients into the scanner and do the tests and look at what was going on in their brains. And then what happened, I guess I'd published 20 or 30 papers at the point, and people started to write to me and say, this test that you've got of frontal lobe function, it's really interesting. Can I use it in my Alzheimer's patients? And I would say, sure. Back in the day, I would mail a floppy disk to the other side of the world. And then eventually the floppy disks became USB sticks. And around about the early 2000s, I thought we need to put this on the internet. I can't be spending my entire life mailing USB sticks to Albania and things. This is what happened. We put it onto the web. Again, it wasn't a commercial enterprise. It was a scientific tool that we were trying to make available to as many different institutions as we could. Very quickly, we got up to 200 or 300 peer-reviewed publications, and maybe 50 or 60 from my lab and the rest from other labs around the world who were using my tests. And then I was introduced to Mark Lipton, who is now the CEO of Creyos, around about 2013, I think. And Mark said, I think this is something that you should make even more widely available. It's going to need to be commercialized and turn into something that people could actually use very widely. I'm not a businessman. I don't have a business bone in my head. I'm a scientist. And I would say Mark would probably say the reverse. He's very good at understanding how companies work and how you've got to structure a company and set it up and distribute your product and so on and so forth. So I think the two of us made a great team. And we started Creyos. It was originally called Cambridge Brain Sciences, but it changed its name to Creyos more recently. And we started in 2014. Mark built the company in Toronto. I continued to build the science in London, Ontario. And we have a very symbiotic relationship. The science gets developed in my lab. It gets shipped to Creyos, incorporate anything new into it, into the company, into the product, which of course then we're free to use in the lab. So That's how it works. And the company's gone from strength to strength, as I'm sure. And I think science has also benefited enormously from the commercial spin off as a company.
That's fascinating. So I do know, again, so many questions I've asked you, a few things. So I do know that there are other tools out there. What would you say would be the differentiator between what you're doing at Creyos versus, say, other tools that might be out there that clinicians or other executives may look into?
That's a really great question. And there's a very straightforward answer, I would say. The and it actually goes back to something we were talking about just a few minutes ago, the pandemic and COVID. This sort of area of online cognitive assessment, whether it be for predicting dementia or assessing concussions or looking at brain injury or looking at ADHD, it's really exploded in recent years. There are many tools out there. In part, that was because of the pandemic, that people suddenly needed sort of online tools. It was no longer practical to send somebody off to see a neuropsychologist. You had to work out how you could do this online. And I would say a lot of people, perhaps most people, jumped on that bandwagon, which means that these are very young companies. Most of our competitors are extremely young. They put themselves together really since the time of the pandemic. The other point is, in many cases, if I would say most cases, all they've done is digitized existing tools. And remember what I said at the beginning of this conversation, that in the 1970s and 1980s, we were fascinated with just measuring how good people were at things. Can they sort cards? Can they tell the difference between two types of shapes? A lot of the tools that are available, most of our competitors are using just digitized versions of the same thing. And there's no magic involved in doing that, putting something on a computer and making it run automatically. There's nothing special about that. It doesn't give you any more information really than doing it with a paper and pencil. And you're certainly just, again, measuring performance. That's not what we're doing. The Creyos tasks were developed. We've got a 35-year history now. They started being developed in 1988. So they've been around a long time. And they were developed to just measure how good people are at things. They were developed specifically to understand brain function, to understand the underlying brain regions and networks that go wrong when somebody is unable to do something. And I get asked this question a lot by clients of Creyos. I'll say, why are you different than so? And the answer is that I think we're actually measuring the brain. And that means I can give you much more information about that's what's wrong with you. When you come into our clinic, I don't send you away saying, unfortunately, you can't sort cards anymore. I say, you've got a problem with the mid-dorsolateral frontal cortex of your brain, and this is where that is, and this may be why it's gone wrong. And that's really important. And I can say that on the back of maybe 300 or 400 peer-reviewed publications in scientific journals that have used our test. So I think if I want to simplify the argument, scientific rigor and validity is what we have on our side. And I think that's probably what most of our competitors don't have.
As a researcher, I love that.
Yeah, that's exactly why it is, right? It's because that's what I am. That's the background I come from. As I said, I'm not a business person. I didn't set out to make money out of this. I set out to try and understand how the brain works and how the brain goes wrong. And yeah, that's why I love it too.
You brought up the business side, and so I want to shift into talking about the American healthcare system and pick up on some threads that I brought up earlier. So people in the United States, and I'm sure across the world, access to food, access to healthcare, people are living longer, not necessarily healthier. And so the healthcare system, recognizing that there's a physician shortage and that we have this conundrum of more patients than we can possibly treat or treat well, that we need to, rather than be reactive, be proactive. And so focus on preventative health, focus on identifying conditions earlier, identifying what conditions are existing so that we can anticipate where the care journey may go. And so there's these functions of quality. So doing screening, you mentioned ADHD, so screening adolescents for those things. Screening adolescents for depression is important now, as well as recognizing and diagnosing dementia early And then there's a whole host, right? CMMI, which is a part of the CMS, has come up with this model guide that is specifically addressing, because again, people living longer, not necessarily healthier. And so maybe the increase too in dementia in the world, in the United States, is just a mere fact of people living longer. Maybe it's environment, who knows? But talk about how your tool can help with that, is supporting that, and maybe even share some work or maybe some health plans or other medical groups that you might be working with currently.
Sure. Yeah. I'm going to get a bit statistical on you now. And there's really
Love it.
two, there's
Bring it
two
on.
issues. There's really two things that are important here, and they're both statistical terms, but I'm going to talk about them in non-statistical ways. There's sensitivity and there's specificity. And sensitivity is how good are you at detecting typically a small impairment when it's there. And obviously, in many of these situations you've described, sensitivity is really important because you want to detect problems early, and you often want to detect small problems. This is why many people go into adulthood before they get diagnosed with ADHD, because the challenges that they've been living with are relatively subtle. They may have always felt there's something wrong with them. They may have seemed a bit odd to their family, but really to narrow that down has been difficult because it's an issue of sensitivity. It's something that you need really sensitive tools to be able to detect. Same with the early stages of dementia. Most people are well on their way to dementia at the point that they turn up at their neurologist and say, I think there's something wrong with me. They're often quite a long way down the road at that point because they don't get exposed to sensitive tools that very early on, maybe they're in their 50s, can say, you're actually deteriorating. Now, you were an 11 before and you're now a 10. And this time, in 3 months' time, you're going to be a 9. You're still operating at a very high level, but you're clearly going downhill. And that's an area that I think we're really contributing to. We have extremely sensitive tools. And again, it goes back to the science. Over the years, I've used the Creyos battery to look for really small changes that are related to things like ingesting caffeine. Trying to say, can we tell the difference between somebody who's had a cup of coffee and somebody who hasn't? Can we tell the difference between somebody who's just got off a treadmill versus somebody who hasn't? The answer is a lot of the time, yes, we can. It may not be with a single test. It may be with a combination of tests, but the changes in the pattern of impairments tell us where somebody is in terms of their sort of cognitive ebbing and flowing through the day. And that means that the tests are really sensitive. They're really sensitive to real problems that people are going to get. If you can tell the difference between somebody who's had a cup of coffee and somebody who hasn't, then, the likelihood is you're going to be able to detect the early stages of dementia. The other statistical term, specificity, is working out. The specificity is really, are you able to specify what the problem is? And think about it in terms of many cognitive tools will tell you that you've got an impairment, but many different populations of patients will be impaired on that task. And this goes back to the old sort of traditional methods of testing cognition. There are things like the mini mental state and the Montreal cognitive assessment, and anybody that's been a dementia clinic will be very familiar with these terms. They're quick and dirty questionnaires that ask you things like, do you know what day of the week it is? Do you know where you are? Can you tell what this picture is a picture of? And these sorts of things. These tools will tell you if you've got a serious impairment, but they won't tell you why at all. And a patient with Alzheimer's disease may perform poorly, but so will somebody who's had a big bang on the back of their head due to a road traffic accident. So they're non-specific. And that's the other area where I think we're making a really big contribution. That is specificity. So I'm not going to tell you, you've just got a problem with your ability to remember stuff. I'm going to say your problem is characteristic of what we see in somebody with a dementic illness versus your problem looks like, your brain has suffered some damage, but it's not progressive and it's in a particular area of cognitive function. Maybe you're specifically impaired at aspects of attention, which depend on this part of the brain. So again, because the Creyos tests were designed in a lab and in a lab over 3 decades, we have specificity in us. And I think that's making a huge contribution. There's one other thing I want to mention that I'm really excited about, and that is big data. Again, and this is one of the sort of incredible as a secondary advantage, I suppose, of having the tests online and having them being around for so long, we have millions and millions of data points. I lost count. I used to have a slide that I would present in conferences and things that said, we've just passed 10 million tests, or we've just passed 11 million tests. I think of 14 million, I stopped updating it. But we're somewhere, I'm sure, not far south of 20 million test results now. That's an enormous amount of data. And from that data, we can do new stuff. We can devise new things. I'll give you some really simple examples. Instead of just saying, this is a test that, I don't know, people with dementia are impaired on this test versus people who aren't. We can actually stage it and say, given the level of your impairment, this is where your dementia is likely to be, or this is the type of dementia you're likely to have, because we have so many tests. And again, for me, it's fortunate that the commercialization of Creyos has resulted in a 10, 20, 30-fold increase in the amount of data we can collect. Whereas in my lab, there's a limit to how much data I can collect. Out there in the world, Creyos is being used by so many neurology clinics now, particularly in the United States, that the data is coming in. Now, so obviously some of it we can't use because we're not given permission to use it. We don't use people's data when we're not allowed to, but we often enter into collaborations with some of the larger clinics. We enter into collaborations and we use the data in an anonymous way, but to try and make predictions. And the more patients with actual Alzheimer's disease that we're able to test, the better able we are to tell that somebody else has got Alzheimer's disease when we see that pattern of impairments. And if you're doing that based on 10 or 20 patients, which is the tradition in neuroscience, then you're probably not going to be very good at it. But if you're doing it based on 150,000 patients that you've seen and have all done exactly the same test, you become really good at the art of detection, at being able to specifically, sensitively detect what's wrong with somebody and make predictions about what's likely to happen to them in the future. For me, the commercialization, that's really the biggest piece, I think. It's all the data that we're getting that is allowing us to answer new questions about all sorts of brain disorders.
You mentioned earlier, that was getting to my next question, actually. You talked about the floppy disk to the USB stick to getting it online. How accessible is the tool and how easy is it to use and to participate in as a patient?
So I would say that's the piece that the company has contributed most to. I should say that Creyos was first spun off via academic funding. It wasn't just a bunch of people that said, we can make some money, let's sell this thing. It was actually spun off. I had a grant to move my whole lab from Cambridge in the UK, where I was on faculty for 16 years, to the University of Western Ontario. And as part of that grant, it was a federal Canadian grant, there was a sort of a commercialization aspect to it. We were meant to try and find ways of creating jobs for Canadians, creating opportunities in Canada. And I chose to do that through the commercialization of Creyos. So it was commercialized as an academic tool originally. But in the 10 or 12 years since Creyos has become a commercial tool, a lot of work has gone into making it incredibly easy to use and incredibly accessible. The reason, if it wasn't beforehand, I'm entirely to blame because I coded a lot of the original tests myself, and I'm not an expert. I'm quite good at coding, but at least I was back in the day. But I'm not necessarily a web expert and an expert at making things accessible. By having so many super smart people at Creyos, there are people that work on web development, there are people that work on the user experience, there are people that work on accessibility. How is it that people track through websites? It's incredibly easy to use. It runs on an iPad now. Back in the day, we had it running on a desktop computer with a mouse. It's all run on tablets now. A lot of work has gone into making it self-administered, and that's really important. So no longer do you need to sit down with a trained professional teaching you to do it. You can do it yourself at home because there are full instructional videos that make sure you know exactly what you're doing before you start the test. It then takes the test. There are things built into it that detect not if you're just performing badly, but if you don't know what you're doing. There's something called a validity indicator that will detect if your behavior is unusual. Not unusual as in you're just not very good at the test, but unusual as in this pause between too stimuli is too long, you probably went off and made a cup of tea. There are other sort of things built into it. Again, make it very straightforward to use. It's available in multiple languages. It all runs on any web browser, so there's no software to download. You don't have to download and install things. You just run it on your web browser. All the data is immediately uploaded to the cloud into a secure space. And all that stuff has been added through the commercialization. There's money that has been made by selling the products being put into making it more accessible. Short answer to your question is, in our database now, we have kids as young as 4, easy using the test. Elderly people, I think our oldest is 99 in the database, but we have plenty of people well into their 90s. As people will often say to me, people that are going to struggle with the technology. Almost every grandparent on the planet these days has an iPad to communicate with their grandchildren. They know how to touch things on a screen and how to move around a screen. And that has proven to be the case in the use of the test. Low literacy populations, we've tested this in many populations with different levels of education, different levels of literacy, to show that you don't need to be smart to use the test. You don't need to have any particular level of education. You don't even need to be able to read. So yes, it's tremendously accessible. And it's one of the things I'm most proud of, because it's the piece, in a sense, the science was always there. The basic science hasn't changed. The tests are the same neuroscientifically rigorous tests that I was developing in my room with no windows back in the late 80s and early 90s. But what you get is much more sophisticated and visually appealing and easy to use, and available for everybody to use. And that's what Creyos really added to the mix. And I love that.
I love that you mentioned that it's in several different languages, because that's something that's often missed. It's not even so much of understanding the words, but even the structure and the connotation of words and how that can change an answer for someone. So I think that's amazing that you have that. And I just want to make sure I understand too, the test works. It's not just that it has to be longitudinal, right? Where you have one score in 1 year and a score down the road, but you can actually detect patterns from one completion or of one assessment of one test.
Yeah. Yeah, and that was quite a big statistical trick that we worked on for actually many months. People are probably used to the fact that when you read a scientific paper, read about a scientific paper that says the Alzheimer's patients were impaired. Typically, that means you've got a whole group of Alzheimer's patients and a whole group of people that don't have Alzheimer's, and on average, one group is different to the other. It's a group study, and I would say about 90% of cognitive neuroscience is like that. What we wanted to do is to say, can we tell whether one person has changed? Can we say this person is different now than they were 3 months ago? And for that, we developed a measure that in the Creyos world is referred to as meaningful change. And that is not, is this statistically significant? It's actually very difficult to do statistics on a single person. But you can develop a statistic called meaningful change. And that's based on, to do that, you need to have a huge database in your back pocket, because I need to be able to look at the performance on one occasion, look at the performance on a different occasion, and say, is the change I've seen significantly different than the change that I would expect to see in this group of 100,000 people that we previously tested? That's basically how it works. So it isn't a group study. We're looking at individuals. And yes, we are able to tell from time A to time B whether somebody has changed in a meaningful way. But it's done with reference to the enormous database that we've been able to accumulate over many years. And as a full disclosure here, I would say about 10% of my elderly relatives I'm currently testing on a regular basis using the Creyos battery for exactly this reason. They all say to me, can I do this? And it's effortless, because I just send them a link in their email and they click on the link and there they are. They're testing themselves. The data comes in. It's all interpreted and analyzed for me. I don't have to put it into a spreadsheet and work out what's going on. I get told exactly what their scores are. 6 months from now, another link gets generated automatically. I send it to Uncle Bert in England. Uncle Bert does the tests, and I get a PDF out the end that says Bert has deteriorated in a meaningful way on this, that, and the other, but actually he's very stable on his executive function or his his attention or whatever. So it gives you a lovely breakdown, not only of the results today, but how they relate to any time that you've done the test in the past. And that's limitless. You could do it 100 times. In fact, we have one person who's done it over 500 times, who's done the test. And if you're interested in looking at yourself longitudinally every week for a year, it's easy.
No, I think that's fantastic. And then that documentation suffices for diagnosing or diagnostic that you're able to diagnose through the test.
So here, I think you have to be very careful. And I've always been somewhat resistant to saying that we're diagnosing anything. And that's not because I don't believe in the tests. I think we do it better than anybody else. But it's because ultimately the only way you can really diagnose, for example, Alzheimer's disease is when somebody looks at your brain after you've died. Or if you have a very sophisticated type of brain scan, a type of PET scanning, for example, you might be able to tell that somebody has Alzheimer's disease. But ultimately, it's a diagnosis that is made on the pathology on your brain after you die. Technically, it would be incorrect to say that we are diagnosing dementia. However, I think what we can do is we can predict whether you are going to get a diagnosis of dementia. And I think for me, that's as good as it's going to get. I'll give you an example in the ADHD space where, again, if you suspect that you've got ADHD, you're going to go and see a specialist, or you'll see your family doctor first. They might send you to a specialist. There'll be a long lineup, a long queue. You'll eventually get seen by somebody. They'll do 16 hours of testing on you and they'll say, yes, you've got ADHD. But that's because you've got all of the symptoms of ADHD. The person doesn't get into your brain, dig a piece out and find the ADHD cells. It's to do with you having all the symptoms. Now, if we can predict that if you went to see a specialist, you would get a diagnosis of ADHD, for me, that's as good as it gets. We don't say you have got ADHD, but we do say if you manage to get to see a specialist, and you probably should, then we predict with a high degree of confidence that you are going to be diagnosed with ADHD. Same with dementia. That's essentially what we're doing. We're one step away from saying this is a diagnosis, but we're predicting with a high degree of confidence that is the diagnosis you're going to get.
That's important if you want people accessing healthcare in the appropriate way, and utilization is definitely something that we're focused on as well. I've really enjoyed having you, Dr. Owen, in the studio today. It's definitely been enlightening, and I'm looking forward to having you as a future guest, because I think that we've only just scratched the surface on how important this testing is and measuring cognitive function is to healthcare in the United States. So thank you so much.
Thank you. They're great questions. I enjoyed being on very much. Thank you.
Thank you.